Um, just before I hand over to Professor Ramachandran to introduce his colleagues on this special webinar, and I'm very grateful for Professor Ramachandran and his colleagues to give us the spotlight on India. Just a bit of background on this webinar series, and apologies for those colleagues who have already attended other webinars. You're hearing this introduction for another time. So just very quickly, my name is David. I'm based at the University of Geneva and Geneva University Hospitals. And this webinar series is hosted by the NCD Policy Lab at the University of Geneva. The aim of the NCD Policy Lab is really to focus on translation of science to policy, and data is an essential element of this. And the aim of this series is to present different cases, different examples of data, and how this data has been used for type 1 diabetes. This also fits into a wider global agenda, which many of you will be familiar with. For example, the centenary of insulin's discovery in 2021 and its first use in 2022, that diabetes is one of the 5 prioritized non-communicable diseases by the World Health Organization, but that most of the focus has been on type 1 diabetes due to its much larger burden. The World Health Organization has also created the Global Diabetes Compact as part of the celebration of insulin's centenary of discovery. And there was a World Health Assembly resolution on diabetes, which included many elements around data, type 1 diabetes, access to insulin, and other important elements for the type 1 diabetes community. Most importantly, now we have this global target of 100% of people with type 1 diabetes have access to affordable insulin treatment and blood glucose monitoring. These webinars also are part of larger discussions around type 1 diabetes. So there's the Lancet Diabetes and Endocrinology Commission on type 1 diabetes. And these webinar series, the lessons learned, the experiences will help inform the Lancet Commission in terms of this issue around data. Many of you may have participated either online or in person to this meeting that was organized earlier this year by the World Diabetes Foundation, East African Diabetes Study Group, Danish Diabetes and Endocrine Academy, and the University of Geneva. It was an international meeting on type 1 diabetes, and clearly the issue of data came out as an important part of the overall management and responses we developed for type 1 diabetes. Just some specificities of type 1 diabetes. It's a common chronic disease, most frequently diagnosed in children and adolescents, but data will show that it's also most frequently occurring in adults in many settings. As we all know, insulin is needed to ensure survival, but in parallel, there's a wide range of elements that the health system and social system need to provide to ensure proper management of this condition. We've seen an increase in the burden in low and middle income countries, and I'm very interested to see what our colleagues from India present today. And this increase comes with an additional need from the health system and development of capacity to respond to this new and evolving burden. We do know a lot, but we also know that we don't know a lot. There's a lack of data in many contexts on incidence, prevalence, and mortality. There have been previous successful international collaborations, and many of you will be familiar with the Diamond and EuroDiab studies. We have the International Diabetes Federation estimates, known as the Diabetes Atlas. In the past, the data presented within the atlas was for the 0 to 15 age group, then the 0 to 19 age group, and then in the recent new version of the Diabetes Atlas that now includes all ages using data provided by the Type 1 Diabetes Index that is managed by Breakthrough T1D. We also saw that in 2021, 2022, there were a series of publications around the epidemiology of type 1 diabetes. So in 2021, a paper led by Professor Anders Green presented type 1 diabetes estimates for 2017, both for incidence and prevalence in children and adults. And that was one of the first publications in a long time that had looked at the burden of type 1 diabetes across the ages. Then in 2022, there was a another study looking at global incidence, prevalence, mortality in type 1 diabetes in 2021 with projections to 2040. And this study was the basis for the type 1 diabetes index. And then in 2022, a group in Harvard also produced estimates just for incidence in the 0 to 19 group. Together with a group of colleagues, we came up with this idea that we needed a plan to improve the global type 1 diabetes epidemiology and the data we had. And so we wrote this comment in the Lancet Diabetes and Endocrinology, which resulted in the development of a core group of experts, including Professor Ramachandran online today, as well as others. This led to some discussions and a meeting in Dar es Salaam during the East African Diabetes Study Group meeting in 2023, which focused mainly on the issues around type 1 diabetes epidemiology in sub-Saharan Africa. And then later that year, in November, we held a meeting in Geneva with 15 experts from 11 countries. The meeting was supported by the Swiss Agency for Development and Cooperation as part of the NCD Policy Lab, and it was hosted at the University of Geneva in collaboration with the Steno Diabetes Center Odense. And the idea behind this meeting was to develop this concept of how do we move forward with improving our understanding, our knowledge of the epidemiology of type 1 diabetes. And the result of that meeting was the relaunch of the DIAMOND study as the DIAMOND 2A or A for action. And again, this webinar series is part of this collaborative approach of the DIAMOND 2A. So just very quickly, the DIAMOND 2A goals, firstly, is to promote research, not only in epidemiology, but in a wide range of elements around type 1 diabetes, to develop, maintain, and sustain cost-effective health systems that ensure access to essential supplies, strengthening capacity in terms of developing guidelines, methodologies, and training the next generation in epidemiology and public health research linked to type 1 diabetes. The fourth goal is to advance advocacy. So how do we use the data that we collect, the science, for interactions with a variety of stakeholders? And then finally, how do we use our experience and expertise to advance the empowerment of people with type 1 diabetes? And these are just some of the principles that we've developed. So really focusing on data quality and standards, ensuring data security and preservation, compliance with regulations at different levels, transparency, data ownership, and intellectual property rights held by those who collect the data, ensuring ethics are maintained, and then also making sure that data is accessible for a whole variety of elements. And really, these are our three, I would say, components or pillars. So to do data and research, so studies, registers, and throughout the webinar series, we've heard interesting examples of how registers have been developed and the data and studies they allow to develop. Then using that data and research for communication, advocacy, and improving diabetes care through reports, publications, stakeholder engagement. And then also, as I mentioned, a key component of all of this is capacity development. So support networks, study visits, twinning, collaborations. And again, this webinar series just highlights that element of capacity development and sharing of experiences. And then also capacity development for policymakers and other stakeholders around this issue. So this is our fourth webinar. We've had a spotlight on Europe. We've had lessons from different contexts, including Pakistan, North Macedonia, and Italy. Yesterday afternoon, we had a spotlight on Latin America. And today, I'm very grateful for Professor Ramachandran and his colleagues to give us a spotlight on India. This afternoon, we have a spotlight on Sub-Saharan Africa. And then on the 1st of July, we have lessons from Kyrgyzstan, and also Graham Ogle will present lessons from Life for a Child. So really, the aim of these webinars are really just to share experiences between different colleagues, between different countries. It's also an opportunity to further develop our network. The DIAMOND 2A aims to be a network, a collaboration, bringing together different people from different institutions, from different countries, to really think and collaborate on improving our knowledge of type 1 diabetes epidemiology. Also, the aim of these webinars is to contribute to the overall thinking of the Diamond 2A collaboration. What should we be doing? Are there any elements that we need to further develop? And then also, as I mentioned, part of this work will provide some input into the Lancet Diabetes and Endocrinology Commission on type 1 diabetes, seeing that data is such an important part. And I just want to recognize the support of the World Diabetes Foundation, Breakthrough T1D, and the Society for Development Cooperation around different components of this work. And without anything further, I just want to thank Professor Ramachandran and his team and hand over to Professor Ramachandran to present today's webinar. Thank you again.
Thank you, David. And I'm happy to be part of the Diamond 2A group. And it's my pleasure to be a part of the webinars too. And let me first share the slides and then let me see. You can see my slides?
Yes.
Okay, thank you.
Not in full screen though, sorry. There we go. Yes, thank you.
Okay. I'm Ramachandran from India, and I live in Chennai, which is the southern city of India, where I run a large hospital for diabetes and as well as head a India Diabetes Research Foundation for research, education, and training for people who want to take care of diabetes. Most of my work has been on epidemiology of type 2 diabetes, as well as on primary prevention of type 2 diabetes. Earlier, I've been also involved in type 1 diabetes, and we had published case series. But today, what I will do is that I'll give an introduction about India and about the health system that we have in this part of the world. And then it will be my pleasure to introduce two important people, Dr. Krishnan Swaminathan, as well as Mr. Prashanth Mani. Both of them are people who are passionate and absolutely devoted to children with diabetes. And I must tell you that with all the challenges and difficulties that we have in this country, they have done phenomenal work in this field. So it'll be my pleasure, and I'll be specifically introducing them after I finish my introduction. So as many of you who are listening to this talk may not know about, India is a union of 29 states and 7 union territories. It's a large country with 3.3 million square kilometers, with the largest population in the world, 1.4 billion people. So if you compare this with the Western Europe, which is only 1.32, the whole of Europe, with a population of 200 million. So that gives you a comparison of how huge is this population. And any registries, national registries have formidable challenges if you really want to collect data from this large subcontinent, I must say. The population in India is pretty different from the Western countries. 25% of the total population in the pyramid is actually below 14 years. 68% is the working age, and about 65-7%. So it's a very different type of pyramid from the Western countries. The International Diabetes Federation World Atlas published in the 2024 Atlas the number of people with type 1 diabetes in the Southeast Asia region. And as you can see here, there's a large number of young people below 20 years is almost as much as what you have. If you look at Europe, what you can see is that the number of diabetic below 20 is much less compared to Southeast Asia. So we have a large number of young people or children with type 1 diabetes in this part of the world. As far as India is concerned, the 2025 Atlas did not give the data, but the 10th International Diabetes Federation Atlas published in 2021 the number of children with type 1 diabetes was estimated to be 2 million, 2.3 million people in the age group of 0 to 19. So that is a number we are talking about. And that's a challenge that we have in front of us. The organization of healthcare structure in India is pretty large, and a variety of levels are available. Each state has developed its own system of healthcare delivery independent of the central government. However, the central government's the responsibility is policy making, planning, guiding, assisting, evaluating, and coordinating work of all the state ministers. So the health system as such has got three main links. At the central level, the Union Ministry of Health and Family Welfare, the Directorate General of Health Services, the Central Council of Health and Family Welfare. At the state level, you have the Ministry of Health and Family Welfare and State Health Directorate and Family Welfare. And both work independently and with some coordination. And then you have peripheral and local level. In the public health sector, you have at the bottom primary health care, and then you have primary health care and sub-centers. Then you have hospitals, which are community hospitals, rural hospitals, district hospital, and then teaching hospitals. And then you have many health insurance schemes which also run hospitals. For example, there is something called Employee State Insurance Scheme, which run independent hospitals. Then there is another scheme called the Central Government Health Scheme Services for all the people who are working in the federal government offices. And there is another national program called Ayushman Bharat. Then you have other two important agencies, and an agency which is independently working for the different services for the Army, for the Navy, as well as the Air Force, which has got complete different type of healthcare structure. Then you have another large group of hospitals for the railways, because Indian Railways is one of the largest employers in the world. So they have a separate healthcare system for the railways. So there are a variety of health delivery systems in this country. Now that is regarding the governmental sector. Then you have the private sector, which have run private hospitals, polyclinics, nursing homes, and dispensaries. And then you have independent general practitioners, both in the urban and the rural population, who run independent clinics. Added to that, we have indigenous systems of India, the ancient Ayurveda and Siddha, Unani, homeopathy, and even you have unregistered practitioners. You also have national health programs, for example, tuberculosis control program, the vaccination program, infectious diseases got separate programs. When the COVID came, they were very effective. So the national health programs take care of all the vaccinations and control programs for infectious diseases. We also have launched a national program for the NCD, which includes diabetes, but it's still in a very, very rudimentary or primitive stage, I can tell you. So with this, I can just add the challenges in developing the disease registry. The first thing is the large heterogeneous population. Even within the state, for example, if you take the state which we are living, which is called Tamil Nadu, which is the southeastern part of the tip of India, we have almost 65 million people. Then the population of our state is almost equal to the population of the whole of United Kingdom. However, there is a lot of heterogeneity in the total population, urban, rural, as well as many geographical differences. So the health system is pretty fragmented because of the different systems, and patients migrate from one system to the other system depending upon their accessibility and also their eligibility. Therefore, there is another important problem because there is limited digital health infrastructure and an incomplete and poor quality of data. This point of time, I can tell you that the digital world is expanding in India, and the government of India has done a phenomenal job of getting, a digital identity for every citizens of this country, and they're trying to improve the health insurance schemes through that process. There are also legal and ethical challenges because there is no unified legal framework for disease registries. There are cultural and behavioral factors or reluctance to report cases. I'm sure that subsequent speakers will definitely tell you about the cultural and the stigma with type 1 diabetes in families who have reluctance to report cases. Added to this, we have, being a large country, especially in the northern part of India and the northeast part of India, illiteracy is a big problem, poverty and lack of awareness on diseases. Because of the multiple agencies involved, there is a lack of coordination, and therefore, developing and running a registry is a nightmare. Of course, along with the heterogeneity of the population, you have urban-rural divide. Lastly, I'm of course tell you that there is resource constraints, both in financial and personal, because being still a developing country, we still have unfinished agenda of infectious diseases such as tuberculosis and many other infectious diseases, and infant mortality is still high. So NCD is still not a priority as far as the federal government is concerned. So not much of money flows from the budget for non-communicable diseases. Well, having said this, in our own records, when I have been working for the last 3-4 decades in diabetes, we have records of more than 3,000 type 1 diabetes, from which we have published a lot of clinical data. But it is a nightmare to have a population-based data. But I attempted in this paper, which was published in 1996, where we looked at a dangerous way of seeing whether we could develop a registry. And in a population about 1 million children living in the city of Chennai, we formed a registry of type 1 diabetes. At that time, we called it IDDM, and all the children below the age of 15 years were retrospectively collected from the primary source, which are large government hospitals, railway hospitals, large diabetic clinics. And then you have secondary sources from diabetes camps and private diabetologists and endocrinologists. And we used a capture-recapture method and came up with an incidence rate of 10.5 per 100,000, which is almost equal to the incidence of diabetes in the Asian children in the United Kingdom. And in the boys, it is 12.6, and in girls, it is 9.6. And the peak incidence was between 11 to 12 years. That is the first population-based incidence data. And of course, still now we do not have population-based incidence data on type 1 diabetes. It's my pleasure now to introduce these two important young people who are going to give their experience. The first is going to be Dr. Krishnan Swaminathan. Now, and the second is Mr. Prashanth Mani. I must tell you that having worked in diabetes for more than 4 decades, I know the nightmare and the challenges that you have in collecting data and also checking the legitimacy of the data, as well as taking care of it, because these two people who are going to present the data not only did collect data, but they were actually taking care of the needs of large number of children with diabetes. They will be describing that in their own talks, but I must say that they are devoted people and they have a passion for this. with all the limitations of resources as well as no cooperation from the governmental agencies still. And they have formed with their own efforts support groups as well as got a lot of funds from many donations from voluntary organizations to continue their work. So the first speaker is going to be Dr. Krishnan Swaminathan, who's a physician, MD, PhD, and a RCP. And he's a consultant endocrinologist and in Madurai Diabetes Center in Coimbatore, which is the second largest city in our state. And he's the founder of Idayangal Charitable Trust, supporting 2,800 children with type 1 diabetes across India. He has published many papers, and he's also a recipient of the Governor's Award from our state. So, Krishnan, thank you for agreeing to participate in this webinar. And so you are on, and I'm going to stop my talk, and we'll listen to first Dr. Swaminathan, after which maybe I have just introduced Prashanth also so that I can finish my presentation. The second speaker is going to be Prashanth Mani, and he is a type 1 diabetes himself, and that is he living with diabetes from 1998. And this young man is the General Secretary and founder trustee of the Type 1 Diabetes Foundation of India. He is also the founder and president of the Tamil Nadu Type 1 Diabetes Foundation. The Tamil Nadu Type 1 Diabetes Foundation was established in 2018 and has been working on hundreds of unprivileged type 1 diabetes patients, providing them with analog insulin, fresh strips, a part of the educating them, empowering them for self-management of diabetes. He also is a co-founder of Type 1 Diabetes Foundation of India, TIDFI, in 2020, which is also trying to collect nationwide data. And is a certified diabetes educator. He won the Type 1 Advocacy Award in Global Best of His PAT conference in 2022. And of course, he published a paper in Lancet. Privileged to play a role in the National Health Mission program of two other big northern states. And so Prashanth will be talking about his experience after Dr. Krishnan Swaminathan presents his talk. So Krishnan, you're on. I'll stop sharing my slides. Thank you.
Thank you very much. It's such an honor and privilege to be here. I hope I'm audible.
Yes.
And I'll just share the screen. Are you able to see the screen and slides moving?
Yes, it's come.
Okay. First of all, I'm based in the second largest city in Tamil Nadu state, from Coimbatore, and I'm the managing trustee and a consultant endocrinologist based at Idayangal Charitable Trust. And in Tamil language, Idayangal means hearts. So we've been running this organization for around 16 years now. Trained in the UK, London, Scotland, and Cambridge for around 16 years, and came back to India in 2011. And this was started way back in Scotland. And there's just only one vision, to ensure that we're not going to let one single poor child with type 1 diabetes in India suffer for want of best treatment on par with the Western world. So for the next 15-20 minutes, flow of presentation, the burden of type 1 diabetes in India with a special focus on Tamil Nadu state, which is the southernmost tip of India. The challenges, but all the challenges presents with the opportunities and solutions, and the work of our organization in trying to reduce the burden of type 1 diabetes here, and what are the future directions in India. Before I start, I just want to thank all our children with type 1 diabetes and their families. Informed consent has been had for presenting their photographs and for sharing data. Idayangal cannot run with the well-wishers and donors. So we are spending around 15 crores per annum, which is quite a lot of money, and a lot of people open their purses for our cause. We have to thank National Health Mission, Tamil Nadu State, for being a partner to us, the Directorate of Medical Education in Tamil Nadu, We are partnering around 25 hospitals, government hospitals across the entire Tamil Nadu state, their head of departments and the deans. And special thanks to Dr. Graham Ogle from Lifestyle Australia, who has given an unrestricted grant for glucometers and basal insulins through LFAC. In terms of burden, there are supposed to be 9 lakh patients with type 1 diabetes. It's guesstimated. Unfortunately, we don't have a national full-fledged registry yet. It's just a guesstimate. And we believe that there are around 15,000 children in Tamil Nadu state. Again, we have just started a very nascent Tamil Nadu type 1 registry in association with National Health Mission. And Prashanth Mani, the speaker after me, was very instrumental in getting the Tamil Nadu type 1 registry on. The numbers are exploding like anything. Over the last 5 years, we believe that the numbers are increasing by about 5% per annum. Every day, I'm seeing around 5 to 8 new type 1 diabetes in the clinic. There might be a bias because we are a type 1 clinic, but we are seeing the numbers increase dramatically over the last 5 years. Very unfortunate that 70% are from below poverty line families, and it's a huge burden for them. And most poor children, especially girls with type 1 diabetes, a lot of cultural stigma for a girl being on insulin in rural underprivileged areas. I don't think they see past their 20s with recurrent diabetic ketoacidosis admissions, end-stage renal failure and blindness. Again, the Lancet paper said that more than 50% receive suboptimal treatment, by which we mean BD mixed insulins, no basal bolus regime, no HbA1c monitoring, and no sort of regular follow-up, no SMBG and occasional HbA1cs. But the beauty is that, as you're all aware, with high quality treatment, all children can lead very normal, happy, healthy lives. And this photograph, as we call her, called Palpi, she comes from Nagarkoil, which is the southernmost district of Tamil Nadu state, just 8 months old with a glucose of around 800 with severe DKA, now doing extremely well on basal bolus insulin. In terms of our insight, we started with one child in our database way back in 2011, and now we are supporting 2,800 children across India. So we support Delhi, Assam, Karnataka, Kerala, Tamil Nadu, Andhra, and Haryana. So these are all quite big states in India, but our main focus is on Tamil Nadu state and Karnataka. We are surprised by the female preponderance. Around 60% are girl children, compared to worldwide, where I think it's 1:1 or slightly male preponderance, but mostly girls are affected more commonly than boys in our cohort. Because we cater to a rural area, the rural-urban divide is big. 65% is rural compared to 35% urban. 55% of our children are between 6 to 15 years of age, with a mean age at diagnosis of around 12.6 years. The mean glucose at presentation is close to 500, which is around 27 millimoles per liter, indicating that the awareness is extremely poor. Even among educated people, people ignore the osmotic symptoms, and about 50% presentation of new type 1 is through DKA, and that's really worrying, where even peripheral doctors are not tuned to pick up the osmotic symptoms and check for a glucose. And the mean A1C at diagnosis is around 12.8%, which is around 116 millimoles per mole. The biggest challenge in India is the burden in poor families. Rich families, some or the other, can afford their insulins. And it's a devil versus a deep blue sea, where the state hospitals, which cater to poor people, the resources are extremely poor. There is no analog insulin. There is no pen fill cartridges, no glucometer support, no monitoring, no emergency helpline numbers, and nothing. So most children get admitted at least 5 to 10 times every year with recurrent DKA, and unfortunately die before 20 years of age. Whereas if they go to a private center, it costs around 6,000 to 8,000 rupees per month for a child. And the earning for the family member is around 10,000 rupees. So you're talking about non-feasibility of seeing in private centers, and there's no health insurance support in India as well. So parents are caught in a bind where they can't access state hospitals because care is pretty minimal. and they can't come to a private hospital because it's extremely expensive. And a lot of parents start to think that their children are better dead than alive. And that's just very unfortunate, and we're not going to let this happen. And my journey with type 1 diabetes in India started with the story of Arjun. So after 16 years in the UK as a senior consultant in Tayside, Nine Wells Hospital in Dundee, I came back to Madurai of all places, which Madurai is the third largest city in Tamil Nadu state. And this 7-year-old boy, Arjun, for want of 3 days to money to buy insulin, was declared dead at a nearby hospital with severe DKA. And this mother on the photograph behind, she brings this dead boy in an auto rickshaw going home for his final rites. And they cross through an emergency. And some divine intuition, this lady brings this boy into her emergency. So we put the cardiac monitor on, cardiac arrest call was activated. I thought it's going to be a flat race, but fortunately, God willing, his heart had not completely stopped. So we resuscitated him and he put him on our pediatric ICU. And 4 days later, on his 8th birthday, Arjun recovered completely. So this is live photograph in our pediatric ICU 10 years ago, where he came back roaring, and 1/4 the cost of a dinner in a restaurant was the cost of his life. 3 days worth of money to buy insulin. And Arjun now is doing extremely well 10 years down the line. He's now in second year of college in catering, doing extremely well on basal bolus insulin. And for his every birthday, he sends my daughter a gift, even in spite of his poverty. So Arjun's rebirth was the birth of Idayangal Charitable Trust, where we thought we're not going to let one single poor child down for want of best treatment. This kid came 6 months ago, no proper diabetes education, diagnosed with type 1 diabetes 3 months prior, poor incidence of zero potency, children die for want of a fridge to store insulin, no SMBG, rank poverty, and a hot coffee spill in her left hand led to gangrene and necrosis within 24 hours, needing a below elbow amputation. It was such a preventable tragedy, but again, doing extremely well. But the one that did not allow us to sleep for more than a month was this story 2 years ago, very close to our place, just 60 miles from Coimbatore. The first child had type 1 diabetes, and the second daughter also developed type 1 diabetes. And within 3 days, both the parents murdered their children. They threw these children into the river, and they also fell into the river. On the one hand, you might think that this is cowardice, but 2 children with type 1 diabetes, they are seeing their children die in front of their eyes with recurrent DK admissions, and they don't have the money to support a private hospital. And one day in their shoes, I don't think we can survive one day. And it's high time that we have to change it in this day and age. So the triple burden that we see in India is recurrent diabetic ketoacidosis admission, end-stage kidney failure, where there's no chance of a renal replacement therapy for poor families, and blindness and early loss of life. So there are a lot of lackness, I've told you. The empathy, the education and empowerment needs to get better. Even amongst the so-said people who deal with diabetes, the awareness of the nuances of type 1 management is pretty poor. There is no dedicated type 1 diabetes clinic in state hospitals, mostly apart from the nodal centers. The cost of insulins are increasing every year, especially analog insulin in private practice that's unaffordable for people. Again, just for want of a fridge, insulin potency is completely lost, especially India is a very hot country where summer temperatures are around 40 degrees, poor or non-existent SMBG, no helplines, BD mix insulin, and social stigma, especially girls with type 1 on insulin. It's very difficult for them to get married if they're on insulin. And you add to this rank poverty and illiteracy. But all these challenges present us with huge opportunities. And we think there are 12 opportunities here. I think the national and statewide registry, and hats off to Prashanth and Tamil Nadu Type 1 Foundation for getting this on. So August 14, 2024, Tamil Nadu is probably one of the very few states who have started the registry, and the data is coming in. And we are giving all the data that we have from all the state hospitals across Tamil Nadu. I think we really need to start giving high quality insulins and pen fill cartridges rather than the vials that are given in state hospital. The syringes are very painful and the potency is not there because it's not getting cold chain storage properly. We need to ensure that advanced technologies like pump therapy reaches the poorest of poor. About 20% of type 1 are very brittle and they don't survive without a pump. So our dream is to ensure that the most advanced pump therapy goes to the most unreached. We are into a huge refrigerator project where our first question on our case sheet is there a fridge at home or not? If there's no fridge, within 4 days, anywhere in Tamil Nadu state, a fridge goes to their home. And by this, we have reduced DK admissions by more than 80% across states. I think girls with type 1 diabetes is very close to our heart. We need to support education, because once they get educated and go to a university, then they can stand on their own feet. And we are looking into placement support. And this is the job of the government. So we are working very hard with the National Health Mission and the Health Ministry of Tamil Nadu State to adopt, and we are doing a lot of advocacy in association with Type 1 Diabetes Foundation. And we need an exit strategy from an NGO point of view, because unlike cataracts or heart disease, where it's one-off, type 1 diabetes, it's lifelong insulin. So we are doing sustainable livelihood programs for mothers of children with type 1 diabetes to sustain their own livelihood. We really believe that endocrine environmental disruptor is playing a big role. I'm going to show one slide on that. We think that pesticides in food and arsenic in fertilizers are causing something to autoimmunity or causing beta cell destruction. That might be one reason why there's a huge explosion of type 1 diabetes. I don't think everything is autoimmune. Either there is some epigenetic changes that increases autoimmunity, or there is some direct destruction of beta cells. So we are working on that with IIT Madras, which is a very reputed research institution in India. Can we make this insulin pump for a fraction of cost that we get from Medtronic is a big question. We are working on it. Health insurance. At this point of time, if a child has type 1 diabetes, insurance is refused. So Idengal is the only trust, pan-India, where all our children are registered with Star Health Insurance for 2 lakh insurance cover per annum, and the premium is paid by Idengal Trust. And we run the mobile diabetes state-of-art van that goes across Tamil Nadu state for avoidable blindness screening and renal failure prevention screening. So our vision, dream, and mission, this is Dr. Abdul Kalam, the missile man of India and the president of India, who says that dreams are not what we get in sleep, but what prevents us from sleeping in the first place. So we are going to ensure that we're not going to let one single poor child suffer or die for want of best treatment. So Idengal India was restarted in 2017 with around 10 children and 5,000 rupees of my money, low in money, but very high in motivation. But within 8 years, we are now supporting 2,800 children across India. This is the map of Tamil Nadu state, representing all the 38 districts of Tamil Nadu. So from Chennai, which is the northernmost point, to Kanyakumari, southernmost point, we are seeing around 2,200 children. And we have adopted all government hospitals across Tamil Nadu state. So we are an official partner to the National Health Mission Tamil Nadu state. So that's where God's work is. So we work very closely with the head of department pediatrics, and we go there every week. So every 3 months we are in that district hospital. And we not only do free investigations, including A1C, annual thyroid, hemoglobin, retinal screening, but we give high quality analog insulin in pen-filled cartridges, along with a glucometer with 100 glucose strips per month per child, absolutely pain-free 4mm needles. We give freestyle Libre for indicated children needing ambulatory glucose profiles. We are now 250 insulin pumps for the underprivileged. I think we can confidently say that we are the largest provider of advanced technology to the most underprivileged, 250 children, along with the consumable costs per annum. We are doing it. Free fridges for insulin storage. Educational support for girls with type 1 diabetes in the rehab project. And we support as far as All India Institute of Medical Sciences, Delhi, Guwahati Medical College in Assam, Karnataka, Kerala, and Andhra. So these are all some photographs of our camps that we go. This is the nodal hospital in Tamil Nadu state, Chennai. There are 450 children in this institution as well. And as of 2024, we have supported 1.5 lakh insulin cartridges for the whole of Tamil Nadu state. That's 150,000 insulin cartridges. We are seeing miracles. Once we get this basal bolus and the 3 times to 4 times a day SMBG, life changes completely for children. So we are hammering this message to all the doctors. Please ensure SMBG and a basal bolus insulin. That's the least you can do for these children, because children who are grown up for dead are now doing extremely well back to their normal self. So 2,800 glucometers. I've got to profusely thank Professor Graham Ogle from Australia. giving this unrestricted glucometer support and basal insulin support. Now children are able to do 3 times a day glucose testing, which has completely changed the way we manage type 1 diabetes. And when we started this program in a lot of state hospitals, government doctors, in fact, challenged us, saying that poor children will not do SMBG. They can't do 3 times and 4 times insulin. But this is just a snapshot of one of our underprivileged children from deep into Salem district, beautifully monitoring the glucose levels along with 4 times a day insulin. And it has 800 memory glucometers, so that they can't escape us. We go through the memory each time we see them. So the pain-free needles has revolutionized completely. And again, the Bezegular support is from Life for Child Australia through Lilly from US. And again, this is just transformed diabetes care. Previously, it was the vial, Actrapid, and Insulatard. Twice a day is what the bog standard regimen state hospital is. But now all children are on very high quality basal bolus insulin across state. Our dream of advanced technology. So this little kid is from a place called Kadalur, which is a very backward district in Tamil Nadu state. A single child born after 16 years of marriage, very precious child with extremely brittle type 1 diabetes, with the A1C of 10%, in spite of being on basal bolus insulin for 4 times a day for 6 months. And this child needs a pump. And how can we refuse a pump just because she's poor? She just lives in a thatched hut. And now on pump therapy, her A1C is 6.5% for the 6th consecutive time now. And this kid gives the videos for how to change insulin pump sets for across state. So we are seeing a great improvement. And these kids are very smart. IQ levels are very good. But the most rewarding slide for us is these girls, as young as 5 years, 6 years with type 1, now going to work, educated, getting married, and coming back with their own children. So last 4 weeks alone, we've had 3 normal deliveries, which are practically unheard of in type 1 diabetes. And this fridge project, we have worked very closely with Godrej R&D to try and do a small fridge, a 5,000 rupee fridge, which can store at least 10 insulin cartridges with a temperature maintenance of around 2 to 8 degrees centigrade, a very portable fridge. And Rolls-Royce India is supporting our education project for underprivileged girls with type 1 diabetes. Around 100 girls are now getting supported through this program. And Project Shakti is how do we empower families? So we mainly focus on cow donation. And in Hinduism, donating a cow is sacred. So milking cow, they can earn around 8,000 rupees per month so that we can move on to the next patient. They can sustain their own livelihood. So these are all our cow donations across the state of Tamil Nadu. And I'm a Rotarian from Coimbatore Galaxy. So we work very closely with Rotarians across the world. And we do an advanced sewing machine training course. We have donated around 150 sewing machines for mothers where they can sit at home and do their work and look after their children and earn money as well. So this is our mobile diabetes van, which has a very advanced Remedio retinal camera with AA enablement, so that on just a button on undilated pupils, we can grade the retinopathy and it can come to us straight away and referral to an ophthalmologist done immediately. And in a drop of blood, we are able to get HbA1c, creatinine, thyroid, cystatin C, and hemoglobin. So all children across state, all underprivileged children get all the investigations that anyone in the Western world will get. And in terms of research, we are really focusing on areas where there is a lot of agricultural villages, agricultural areas. We see a huge burden of type 1 diabetes and industrial areas. So we are working on pesticides, heavy metals, in terms of autoimmunity or direct destruction. And this is our published paper. This is a very landmark paper, we think, because the government alone in India can't do everything. The resource crunch is extremely high. So we believe that an NGO like us, along with the government, industry, and we call something called the CSR partnership, which is corporate social responsibility. Every profitable company has to give 2% of their profits towards a social cause. So Ideal is able to raise enormous amount of funds through this. And I think this kind of combined partnership will reduce morbidity and mortality in a very big way. And this is our paper published showing DK admissions coming down by around 90% across all government hospitals in Tamil Nadu state by this focused method of basal bolus insulin, SMBG, 24/7 telephone support. So we have diabetes educators in every district of Tamil Nadu who are on 24/7 emergency helpline. And the HbA1c has come down from a baseline of around 11.5% to 8.7%. So we are working hard to try and get it to less than 8%. And this is our landmark paper on International Journal of Diabetes in Developing Countries of the experience of insulin pump therapy in the most underprivileged population of around 200 pumps. And this gives a blueprint of how to use insulin pump therapy in low and middle income countries. So I'm happy to share this paper to all the participants here. And we have published a lot of data on how to break socio-economic barriers in diabetes technologies. And we are the first paper on how to predict basal insulin requirements on pump therapy. So I think we've got enough data on all these issues to try and give an idea of how to start this very safely, securely, and for the long term. So just to summarize, 2,800 children supported across India with whatever numbers you've seen there. But the most rewarding thing is the 2.5% reduction in A1C across government hospitals where we thought it was not possible, and more than 90% reduction in DK admissions and hypoglycemic emergencies. And I am sure it translates into huge reductions in renal failure, blindness, and improved quality of life. But the unmeasurable things are what excites us. For the first time, the joy of the parents to see their children recover from death. For the first time, we are seeing hope in the mother's eyes that their child can too have a life. We are seeing young children saving 1 rupee, 2 rupee coins to be donating to Idengal Trust for other children. We are seeing mothers who have lost their children come on stage to plead and tell how to take care of the diabetes. We are seeing mothers for the first time delivering babies. They were told that they can't get married and they can't have babies, now being very proud mothers. 4 of our trust children have joined medicine last year, which is a great thing. And mothers wanting their lives to be transferred to Team Idengal for our team's work. So we've got a fantastic team which works 24/7 with the same ethos. We pick up our phone call first ring 24/7 because 3,000 children have our numbers. I think the need of the hour is we need this NGO, NHM, Directorate Medical Education Industry partnership if you're going to move further. There's an urgent need for a nationwide and statewide diabetes registry to understand the burden and how to get resources going into the right places. We have now been approved to start 5 centers of excellence across Tamil Nadu state in 5 big areas of Tamil Nadu, so that any child goes in there will have the best treatment on par with anywhere in the world. We have to train the trainers and no child in any nook and corner of India should suffer for want of best treatment. So I just want to finish by reiterating our core values. We not only identify children, we control, we stabilize, we educate and uplift. So thank you very much for this opportunity. I'm happy to hear about other people's experience and see how we can do better. Thank you.
Thank you, Krishna, for the fantastic presentation or the excellent work you're doing. I think we'll now ask Prashanth to talk about his experience, after which we will see whether people want to discuss, have some questions. Yeah. Prashanth?
Yes, sir. I'll share my screen.
Yes.
Yeah. Yes, sir. Hope it's visible right now.
Yes, go ahead.
Yes, sir. So, yes, I think Dr. Swami and yourself have covered most of the areas. So I'll just get into the registry part and maybe a brief introduction of how we started the registry. So I am a type 1, as Doctor said earlier, since 1998. So 27 years of living with type 1. And then our group is all we comprise of volunteers. And we also have doctors who themselves are type 1s, as they were diagnosed as type 1s, but they went on to become doctors. So we have some 15 to 16 doctors like that, and some around 20 diabetes educators. And our group consists of around 700 people right now. And yeah. And I think breakthrough T1D index is the first large scale data which has come in 2022 September. And this is the data then which we have taken, just of it what I'm showing. This is for India, close to 1 million. And then it also tells about the number of people who should have been alive today. Of course, they haven't lost their lives immediately. 5 years, 10, 15 years down the line, they have lost their lives. So those T1s should have been alive today. So that is almost 800,000, which is around almost half, 40%. And also the number of healthy years. So I'll get into the data of that as well later in detail. So 42 years of healthy years is lost. That is, if a T1 is diagnosed at 10, they just go on to live on an average only till 32 in India. So they, on an average, 42 years of a healthy life years are lost for T1.
So,
And these are the data.
sorry,
Yeah, so
I don't know if you've switched your slide, but we're still on your first slide. Apologies.
yeah, I'm coming to that. Yeah.
Okay.
So, yeah. So with the National Health Mission, so as doctor said earlier, like we have a central National Health Mission, also state-wise. So till now we have covered around 4 states, and each state is in the size of almost the population of Europe. So it is almost the population and numbers are like pretty huge. So with partnership of National Health Mission, and there are some NGOs like Clinton Health Foundation, Breakthrough T1D, and UNICEF, we have been able to devise a structured program. We already have ICMR guidelines, but then there are something which are on paper. But as Dr. Swami said, there are still general practitioners, general physicians who are still prescribing mixed insulin for T1s. So these are the basic treatment protocol that we came up with 2 years back. And this is something training program we are doing for all government hospital doctors state-wise. And this is another data which I think on the right-hand side, you can see non-diagnosed 10 years. For example, of course, if the child gets not diagnosed, they lose the life immediately. And 29, they live on till 29 with pre-mix and very few tests, no SMPG. And with basic care, when we said basal, bolus, and SMPG and more follow-up, till 54. And with advanced technology of sensor and other gadgets, yes, 60 extra years. So from 10, the child goes on to live till 70. So these are the
Prashanth,
data.
are you changing your Prashanth, are you changing your slides here on this?
No, so this is the same. Yeah.
Oh, okay.
No, this, I think, yeah. So hope you can see the 10, 29, 54, 60 on the right side, sir.
You're speaking on the first slide, same slide, is it?
No, the
slide has not changed.
One second, sorry. Just check. No, sir.
Okay, done.
Yeah. So this data you can see on the right, this 10, 29, and 54. So
yes, fine.
Yeah.
Good.
Yeah, so this is the numbers we said. First is the non-diagnosed, where the child gets diagnosed with 10 or non-diagnosed, and then 29 with pre-mix, that is mixed insulin and fewer tests. 54 more years with basic care, that is analog insulin and SMBG, and with advanced technology, 60 more years to the life. So this was the basic treatment protocol which we devised, and the data which Breakthrough T1D had given it in 2022. And next, there is country-wise detail also on the website. You can go country-wise and also comparison. So when you compare India, which is a developing country, but still when you look at the average life span of a T1, it ranks really low. Of course, UK with It's NHS system, and right now they're in hybrid closed loop system and sensors. I think almost 6 years back they started it, and from last year they started with the hybrid loop. Now you can see the life expectancy is around 77 for a T1. So T1s can have a really healthy quality of life if care is given. So these are the data that you can find on T1D index, which is on the breakthrough T1D. And you can use this data, use your logo and share it, and feel free to share whoever wants to in any form. So it's there on the website. The source is being mentioned there. Yeah, so you can see the number of years also, how many with basic care, the years of life that T1D can get. And of course, about our foundation, I'll just go very briefly. As I said, we are a volunteer-driven organization. We go to government hospital. This is from the Chennai Rajiv Gandhi Hospital, which is the main hospital here in capital of Tamil Nadu, where with the children, we go and tell them how to take injections and convince them. It's more about adherence to the regimen, because there are many people who reluctantly take 4 injections. They almost plead to the doctor saying, "You don't want 4 injections, we just need 2." So this is something that we've been trying to do. And also we do some educational workshop where you can see in the background, we do some, as you say, as I think the literacy rate, people who can't read and write, even in villages and towns. So those are a target audience, because English speaking T1s, we believe that they will find some source of information somewhere. So we started creating content in the local languages. So it is written in Tamil, and also there are people who can't read and understand. So we kind of make them understand, even the child, maybe even a 10-year-old child can understand what insulin does and how it goes. So this is just a few screenshots of the education slide that we are doing, cartoon based. And we break this stigma as well. Like once you go to the workshop, we take an injection in the public on the stage, saying that you don't have to feel the stigma or feel bad about taking an injection. It is something which is keeping us alive. So these are things we go to hospitals, and this is our team with the blue t-shirts, and calling the kids who have come there for the workshop, telling them, okay, please take the injection along with us. This is just before the lunch. Of course, before the lunch, we all have to take an injection. So this is how. And coming to the registry, so I'll start how. So the health minister, he's also a marathon runner. He is also a person living with type 2 diabetes. So he's been living with type 2 diabetes for more than 2 decades, and he got onto running. And what we did was 5 years back when we launched our foundation, that is the India Foundation for Policy Making, when Dr. Swami was there. We said the first and foremost request for us was to start a registry, because without registry, no policy or no program falls in place. So when we asked for the registry, which was 5 years back, March 2020, just before COVID, we started. And till now, there is no country-wise registry. But then, of course, this being in my state, I went to the health minister's house at morning 5:30, waited for an hour, because 6:30 comes for his running, tried to meet him several times. Then we presented a petition and request. Then this was in January 2023. And on April, that is after 4 months, on the Legislative Assembly, he did announce that the state level registry will be created for the treatment and management of type 1. And after many rounds of discussion with the National Health Mission and looking at discussion with all the doctors, on August, so that is almost more than a year. So I think it is almost like 17, 18 months. After that, we got into a MOU saying that there'll be an online portal starting with the registry of the type 1 kids and adults. And the type 1 registry, it was started with their on their website portal. So it is an online portal. We call it MTM portal because in Tamil it is called Makkal Thediya Marthuvam, because the medicine in search of people, that is, instead of people coming to the hospital, there is a scheme where they say the medicine reaches their doorstep. So it is called the MTM portal. It is there on their website. And even the data collection. So the data collection, as I mentioned here, it is on 14th August last year. So the difficulties once we started facing were like the number of parameters that has to be filled in were almost more than 20 plus. Looking at the child's name, father's name, their social security, we call it Aadhaar card here. So Aadhaar card, and then looking at their block number, primary healthcare center number, then the child's diagnosis date and what insulin it takes, and there was too many parameters to be filled in. So once the NHM, that is, I'll just refer it to as NHM because the National Health Mission. So once the personnel started calling these T1s, they were not trained, and there were so many parameters which they were asked, and the parents were not ready because they themselves didn't know this information, what the name of the insulin the child is taking, because once the insulin is given, they only know the colors, or here we call it, if they give mixed insulin like regular and NPH in the government hospital, existing insulin supply, they call it water insulin, milk insulin. So that is all they know. They don't know the names. So these were the difficulties where even the data entry staff, the technical staff also were facing it to give full details. And yeah, so as I said, again, fragmented data. So again, public and private. So I'll finish the public sector first. And these were the news headlines which said free treatment of type 1 diabetes and all that. It came over all newspapers in Tamil, every language, and English and all that. But till now, even the registry is not completed. And yeah, so the number of children under 14, these have been already discussed and put by Dr. Swami as well. Yeah, and 80% it is out of pocket. And the stigma. So again, one most about stigma, what we have faced is there are T1s who don't even go to the doctor. Once they're diagnosed, they get their insulin, they remain in their house, they do self-care without any understanding. They don't want the society to know that their child has type 1. So even in our patient support group where we are only T1s, they're reluctant to join there as well. They call me personally, they just say, they don't want to go for blood checkup. They don't want to go to the doctor. So the stigma is one thing. And even the trained personnel, the staff who calls them, just randomly calls and asks them that, because we have given the phone numbers, they just call them and ask, okay, does your child have type 1 and all that? The parents say that, no, we don't know who you are, and we don't want to give the information. So even that was another difficulty, because all these numbers we couldn't call them personally and say that, okay, you'll be getting a call from the government. When they called, they didn't introduce them properly, and that was another problem. And also the purpose, I think the purpose of the call was like, at least if they had a introduction saying that, okay, this is to give free insulin supplies or to get at data, they were not introducing themselves properly. And right now, I'll just go to the first one second. Yeah. And the estimate in breakthrough T1D also, what happens is, what they said is, for example, a state like Rajasthan, where they did a state-wise estimate, which has the same population as Tamil Nadu, they've estimated the numbers to be 54,000. So right now we are only at 4,000. So after 10 months of starting the registry, it is less than 10%. So less than 10% has come, and these 10% has come from government hospitals. And government hospitals, the T1s whom they have approached, so that is a very less number, because they don't know there is a scheme in the government hospital. For example, I'll just show you something, that I am a person who can afford insulin. I'm 47, 46 years old, but yes, I get the best insulin from the government hospital free of cost. So this is in one hospital, and the disparity in the healthcare system, I would say that just less than a mile from the hospital that I'm getting this analog insulin, a child, a toddler, 1 year old or 2 year old child gets a vial and syringe. So this is the disparity in insulin supplies. And also the data entry in the government hospital. Why even the government hospital, at least if the government hospitals had given their data to this registry, the numbers would have been high. But even the data in the government hospital, for example, this is my medical record. I think you can see the book. It's been overused for last 3 years. It has been filled by a clerical staff, handwritten. Each time I go there, they have a seal to supply. They just write it. So this is what has been happening. And this data, for example, if I lose this book, even they don't have the data, even I won't have the data. So there is no electronic medical data. So EMR is very key, and they have not changed the system. This is how right now the existing system is going on. We've requested them to change it so that the data remains. And also, once this is electronically shifted, then maybe even during the course of the next 1 or 2 years, all the data would come to the government. And for example, this analog insulin scheme was available. We didn't know it was available. One of our T1s who went there to get admitted as a dialysis patient because of his complication, there they told him, okay, you're a T1, we give free insulin. So that is how we came to know. And then we started sharing the word, and that is how even government schemes are not known. So if that T1 wasn't admitted there, even we wouldn't know that there is such a scheme there. And all these years, for the 5 years, we've been sending so many petitions and requests to them, all notices but we haven't been communicated that there is a scheme started or a registry started. So only the registry, of course, it has started. And yes. And initially, as it said, in the first month, there was a spurt of good data coming in. So I think the first couple of months, you can see there was like 2,600. But after that, now it's been 10 months, it's only 4,000 T1s. And as I said, maybe more than 40,000 are still yet to come into the registry. And another challenge what they have faced is getting the line list or the data from private hospitals, because most of the people here, they don't go to government hospital because they are unaware of there is such a scheme. So they go to the local physician, even a general physician. They go to the doctor, they spend out of pocket, they buy their insulin from the medicine, or say, for example, Dr. Swami's NGO is supporting, but not the majority of them can get help or assistance from them. So due to this unawareness of the existing structure, even the government hospital don't cover enough type 1s. And once the registry was started last year, the government, I would say, hasn't done enough to get more data from their own government hospitals, because once there is a problem with the login detail, there is a problem with their login coverage, or there are some government doctors who are reluctant to do this work because they are already overloaded with too many patients standing outside their door night and day, and they don't have this time to spend for the registry. There are few committed doctors, yes, who have come and taken their time out and fill in all the details and send it. So they're facing a very difficult time. Now, after this, once they come into the private sector, then it is about privacy. The private clinicians, they might feel reluctant about giving the data of such person. So unless a government directive goes to them saying that we are starting a registry, we need to know the numbers, this is not going to happen. And there are T1s from many private hospitals and government hospitals in my group, but it would be unethical for me to give all these details, because each hospital on an average will have 200, 300, or maybe even some large hospitals, 700 T1s. And there'll be hardly 15 to 20 from that hospital in my group. And instead of me giving this small numbers, it has to go through the right channel, through the doctors and through the hospital. For example, now Dr. Swami has so many T1s in his hospital, and there are few T1s in my group. And it would be unethical for me to give these numbers to the NHM, and it should come through Dr. Swami, because he should be giving that data to the government, and that is how the data can be complete. So that is why we have a very fragmented and incomplete registry as of now. And these points have been already covered, so I'm just skipping this. And And again, in rural sector, the T1s, so we have a very difficult time for these patient support groups to go and tell them to come to our workshop or come learn with us. It is just about, we don't have any membership drive or any fees. It is just turn up at the workshop, we will teach you self-management, and then you can go and take care of yourself. Even for that, we have to give them kit bags and other freebies. Only then they feel that, okay, they're giving us something, let us go. So we have, our workshop is from 10 to 5, the full day workshop. And even all those food and all the arrangement, it is made by us, which is mostly out of pocket. So we find it very difficult to cover all these, so many large numbers. Yeah, and yeah, privacy we've discussed. Yeah, and one more thing, what Dr. Swami showed the picture of a family where 4 members of a family drowned, and of course they were killed and then committed suicide. So this is the part where that couple and the children didn't have support. They didn't approach anybody. They were not in a patient support group. Now I will tell you the positive side of the story. So this happened in 2022, as you can see the date on the newspaper article. Now this is another story which happened last year, 2024 November. Similarly, 2 sons aged 9 and 11. So similarly, this parent showed signs to the doctor that they are going to commit suicide once they get discharged. So when the doctor said they were like reluctant to speak, they asked me to give them a call. I tried reaching out to the father. The father was so broken, he didn't want to talk to anybody. After 3-4 days of perseverance, we talked to them, we convinced them, and then he broke down saying that, okay, we had this plan of committing suicide, now we will not do it. So this is something that patient support groups can actually bring in. The doctors can do the medical care, the government can give the supplies, but something from the patient support group where we have the empathy and we will not let another T1 who has come in under our radar, and will not let them suffer. So this is something that positive story is also there. This is the one such story which came under the newspaper headline. And one thing about data will be type 1 data and numbers. We usually have a saying that we are not just numbers, we are people. We are people who need quality of life. We deserve the dignity and respect no matter from which background they are. So I think more empathy and ethical way of sharing the data is something very primarily important. So that is something that we've been very, very particular on when the data and other numbers, and because these are data of vulnerable children and they can be exploited in many ways. Because I have had experience for the last 5-6 years from different pharma companies and other ways. Yes, so the data has to be used for a good purpose, and also it is for the care. If it is going to empower a T1, if it is going to save a life, yes. But otherwise, if it is for some other purpose, then we need to take care of the data. So that is something that we have seen for the last 5 years. And I will stop with that. And any doubts or questions about the registry have been little here and there, I understand. So yes.
Thank you, Prashanth. I think you heard 2 gentlemen talking of their grassroots level experience regarding type 1 diabetes and the registries. David, any questions or any discussion? We have about 5 to 6 minutes.
Yeah, a huge thank you for your for the 2 presentations and the amazing work that's happening. There's a question from Sarah Wild. I guess it can be for the 3 of you. Is, do you see people with features of malnutrition related diabetes in Tamil Nadu?
Yes. So this is something, for example, I think this is a given. So any type 1 child with 5 years or 10 years of after diagnosis, we've seen them, once they've lost the weight, it is very hard for them to gain the weight, because they're, as your doctors, you understand very well, without maintenance of their good HbA1c or sugar levels, they never put on weight. and actually they start losing weight. And there are children who come to my house for counseling. I take the child and keep it in my lap and carry, thinking it is a 4-year-old, and the mother says the child is 15 years old. So the stunted growth after 10 years of diabetes, I'm thinking this child is a 4-year-old, but actually it's a teenager. And we've seen across the board. So type 1s across India, what we have seen is they have two ways of travel. One is with good care, good physical activity. They're much more active and healthy than a normal person. But then the majority of the T1 population with poor glucose glycemic control and high other complications, they lose their weight, they get into complications, and that is how the loss of life and loss of limbs happen. That is how it occurs. Yeah.
David, I can add to that. The malnutrition related diabetes was one of the diagnoses we used to make almost 30 to 40 years ago in India. But the malnutrition related diabetes, we do not see it nowadays. It's much, much rarer. In fact, that's one of the reasons that the IDF and WHO has removed that as a primary classification of diabetes. So as the economy and the nutrition has improved, we rarely see patients which are exactly called malnutrition related diabetes in the young, which we used to see much more often almost 3 decades ago.
Thank you for that answer. I guess I just have one question. I mean, it's interesting to see we've had different presentations around registers from countries like, oh, well, actually, I'll let Dr. Radha ask their questions. Please go ahead, Dr. Radha.
Oh no, I can go after you, please,
No.
David.
So my quick question was, we've seen examples presented from Scotland, Finland, and Denmark, which provide national registers for a whole country that's smaller than the regions that you discuss by orders of magnitude. In terms of the follow-up of these individuals over time, if they move, you describe a very decentralized system. So how does the data follow the individual if within the different systems, within different areas of India, and given the decentralization of the system, would we ever see a national register, or is that just not going to be feasible in a context like India? So just thinking about that difference that we see in Europe in small countries, having national data that follows the individual versus the challenges you face in your part of India. Just some reflections on that, maybe from the three of you.
Yeah, so Tamil Nadu being the first state to start the official registry, but as I said, there are the challenges and whatever, we have not done much, but yes, there is a official registry started. Now the whole country, most of the states which are into having certain type 1 related schemes are looking at our state and they want to learn from that. So they're looking at how it is going to roll out. So that is why I pointed out the problems as well. Because once these problems, because being the first state, we have the teething problems and other challenges. So once we identify this and once this registry is completed, I think more states they'll be having an easier job of starting the registry. But when it comes to the national policy, so when Dr. Ramu said, first, it has to be from the national central government, where these registry has to be started. The NCD, that the scheme right now, what we have is NCD, non-communicable disease, is about 30. And T1D, you know that the majority is about children. So this doesn't fall. So there is a scheme. So this is what we've been trying for the last 1.5 years to bring in type 1 under NCD. And we've almost knocking at the door. Every time we feel that we are getting a breakthrough, there comes some problem. So there is something that we have written on papers, certain things happening, but when it comes to implementation and ground reality, things are different. So of course, we are learning from it and we'll be able to overcome the challenges soon, hopefully.
Thank you.
David, to answer your question, I think it's very difficult to follow up patients for a long period of time because of the change in the system. There sometimes are people who are in the private clinics and they move on to the government hospitals, and from them, sometimes they go into the railway hospital. So there's also the care being transferred from one system to the other. So the follow-up, even within the state, is also a nightmare. On the other hand, a few of the patients, for example, whom I am seeing, like we are a private enterprise, so I have patients whom I have been seeing for last 30 years or 40 years, and because they are people who can afford to see me as in a private clinic. So that is a very different, that doesn't in any way represent the national scenario. Yeah.
Thank you. Dr. Radha, please go ahead.
Yes, first of all, congratulations to both the speakers and their respective institutions for doing really amazing, really commendable work. And also thank you for acknowledging World Diabetes Foundation and WDF's Program Manager for India. My name is Dr. Radha Valadekar. So just a question to Dr. Krishnan for Ideyangal. You mentioned that you have raised CSR funds. I'm not sure if he's still there in the program.
Yes.
Yeah, okay. So you mentioned that you have raised CSR funds from Rolls-Royce India, and I also checked your website. You have a long list of donors. So just out of curiosity, because this is a cause which does not receive substantial funding from the public health side or from the government side, what is your mechanism for fundraising? Is it through your contacts, or how do you manage to get big companies or CSR institutions with CSR capabilities to see this cause? So curious about the fundraising mechanism and its sustainability.
It's a great question, Radha. I keep saying that we are golden beggars now. We have learned the art of begging so smoothly now. The first 2 years was very difficult. But once they see that your honesty, integrity, and the cause, India's CSR funding can fund anything. We don't need any foreign funding, actually. So the CSR funds is around 30,000 crores in India. And all they see is how good your work is. Once you do that, then it's pretty easy, because by the time we've got published papers, we've got all the evidence for the last 5 to 7 years. It's a lot of hard work, but if you keep very focused, it's and connected with people. So everyone is a contact to me now. And being a Rotarian also helps, because we have finished our third global international grant to the tune of $200,000. So I think it's all about connect in India, just the power of a phone call.
Yeah, thank you so much. I just asked because I come from a donor institution. So just looking at the donor landscape and fund mobilization, I think it was from that lens. But thank you very much. Yeah.
Thank you.
Well, unfortunately, the time is up. Again, a huge thank you to our three colleagues for having presented this very interesting work through different lenses in terms of the challenges in one area in India. So again, a huge thank you, Professor Ramachandran and your colleagues, for this. And to everyone online, as I mentioned, the videos will be online as soon as we can, so you can share them with colleagues who are unable to attend. And for those of you who are free later today, we have a spotlight on Sub-Saharan Africa. But again, a huge thank you to our three colleagues from India, and wishing everyone a good rest of the day. Thank you again.
Thank you. Thank you so much. Thanks for giving this opportunity.
Thanks. Thank you, David.
Thank you.
Bye.
Thank you very much.